So principles of pharmacology. Now, this is going to be where I will actually introduce the medications that you're going to be studying for your pharmacology benchmark. Okay, this is also going to be the day that I'm going to tell you some doses, and I would tell you, hint, hint, wink, wink, those doses are going to be pretty important. Okay, so let's get going. So medications, they're going to be an important intervention, right? We've talked about interventions. Interventions is us getting involved. How can we help out? What can we do to better our patients' outcomes, right? We want the overall best outcome for them. Now, up until this point, it's mostly been things like splinting and bandaging, right? BVM, non-rebreather, nasal cannula, all those sorts of things, CPR as needed. This is going to be one that a lot of newer people kind of freak out with. Myself included, especially medics, it tends to happen when we have so many meds, but these can make us nervous, right? Medications are one of those things that we're giving something to someone and hoping it's going to work correctly. We're hoping that we made the right choice, okay? Now we'll go through methods to kind of alleviate some of that fear, okay? And different ways that we can kind of work our way through it and make sure we're not making mistakes, but I'll come to those later, okay? So medications may alleviate pain and improve patient condition. And then failure to administer medications safely and competently can lead to serious consequences for the patient, up to and including death. This is why I'm changing your guys' minimum requirement for retakes. It's 80%, okay? If you give one of these, in particular, one of these medications wrong, you will kill somebody, okay? So we gotta make sure we're not gonna do that. And I'll tell you which one it is as we get there. So, how medications work. First of all, pharmacology is the science of drugs. Our next lecture today is going to be toxicology. It tends to be the more fun chapter. That's more of your illicit substance type stuff. But pharmacology, the science of drugs. These are the drugs, when we say drugs here, like medications, okay? So when we're talking about meds we give, those are medications. When we're talking about illicit substances, those are the drugs. Now, those of us who have spent a lot of time around medications will still refer to them as our drugs. Just keep that in mind. So, medication, substance used to prevent or treat disease and relieve pain. Now, for the most part, relieving pain, those type of meds, that's out of your scope. Okay, that's going to be like our analgesia, the paramedic scope. That said, there is a couple of medications you will give that can potentially help. Okay. Now, one of the concepts of pharmacology is pharmacodynamics. This is the process by which medications work on the body, right? This is what the desired effect of the medication we're giving. We want it to have X effect. That's the pharmacodynamic, how that medication influences the body, okay? Now, we'll talk about it later. There's another definition you'll need to know about how our body acts on the medication, but I'll digress for a moment. So, different types of medications we can give. We have agonists, antagonists. We got to keep in mind the dose, and then we have the action. Okay, so an agonist. An agonist is something that causes a stimulation of receptors. Okay, an agonist is a stimulation of receptors. We have a couple. We've talked about one quite a bit that is an agonist. It stimulates our receptors. What is the chemical or the hormone released during fight or flight? Epinephrine, right? Epinephrine is an agonist. Epinephrine's job is to act on receptors. Do you guys remember the 3 receptors it acts on? Beta 1, beta 2. What's the third one? Alpha. Yeah, alphas are vasculature. Beta 1's cardiac. Beta 2 is going to be our respiratory, right, our lungs. And then alpha is going to be vasculature. So beta 1, 1 heart, right? Beta 1. Beta 2, 2 lungs. Beta 2. And then alpha, artery, vasculature, okay? Now we also have antagonists. Antagonists are medications that bind to receptors and block other medications or chemicals from interacting on that receptor. One of our medications we're going to give that does that, okay, is an antagonist. This one is pretty popular nowadays based on the epidemic. Anybody have any guesses on what I'm thinking? Huh? Not nitro. Narcan. Yeah, Narcan, Naloxone. Narcan is the anti-opiate medication, okay? Opiates respond, or excuse me, they attach to what's called our mu receptors in our brain. Okay, so what Narcan does is it floats in there, it kicks that opiate out of that spot and sits there instead. It's an antagonist, okay? And if you think about, for me, antagonists, I used to think about like books, right? The antagonist is always the bad guy doing the opposite of what you want it to do. It's gonna do the opposite of what that chemical wants to do to that receptor, okay? That's how I used to think of it. Now we also have our dose. Dose is the amount of medication given, okay? Dose is the amount. Now, we'll talk about it when we get to toxicology, to the tox chapter. The poisons that we'll talk about are all in the dose. Dose is a huge, huge thing, right? If we're overdosing people with medications, we're doing harm potentially, okay? But you'll see what I mean when I say the poison, the dose makes the poison down the road, okay? And then the last section is the action. So the action is the therapeutic effect that a medication is expected to have on the body, okay? So kind of a mixture with the pharmacodynamics, right? We want the action and the pharmacodynamics to line up. We want them to be synonymous, that way we're giving our patient the ultimate treatment they need, okay? Questions at all on this so far? Okay. So pharmacokinetics, we had pharmacodynamics, right, which is how the medication works on the body. Pharmacokinetics is how our body works on the medication or the chemical. Right? Now there's a few different things we got to keep in mind when we're talking about pharmacokinetics. Okay, we have the onset of action, we have the duration, the elimination, and the peak. Okay? Can someone tell me what onset of action means, or best guess towards onset of action? Yeah, Bryce.
When you insert it into the patient, like the medication.
When you insert the medication? Not quite. So let's say from this perspective the medication's already administered. What do we want the onset to be?
The dose.
Yeah. When it starts to kick in, yeah, onset. How long is it going to take for this to start kicking in, right? If we're going to give a medication, we want it to work, right? Want it to work fairly quickly too, depending on what it is. Then we have the duration. What do you think the duration is? This one's pretty self-explanatory. How long it's going to last, yeah. Elimination. Guesses on that one? Yeah, how do we get rid of it? Right? Is this going to be something that's excreted through urine, stool? Does it just kind of dissolve away into the mystic wonderlands? Who knows, right? And then the peak, and I'll just say this one because it's pretty obvious. The peak is going to be the top amount or the top effect that medication is going to have, right? The peak effect is what we are hoping for. That's the desired, okay, this is when it is working at its absolute best, okay? Very good. Now, there are some factors that are going to affect how our medications work as well. Okay, one of them is our route of administration, which we'll talk about those different routes here in a little bit. Okay, and the other one is shock states. Now, shock kind of makes sense. We circulate medications in our blood. That's actually how, the faster something hits our blood, the faster it's going to start affecting the patient. Well, in shock, how's their blood moving? Not very well, right? So that can kind of slow things down, especially if we're talking maybe hypovolemic shock. We're not going to use the medication for that state, at least not at this scope. But for example, right, if someone's bleeding all their blood out there, that's not circulatable blood. They're not going to be able to circulate the medication they need inside there. Okay? Now, there are a couple of things that we also have to keep in mind with our meds. We have our indications and our contraindications. Okay? Indications are the reasons or conditions that we will use a medication. Okay, it's pretty specific. Depending on the medication we're talking about, there's very specific things that they're used for. Okay, and then on the inverse flip side of that, we have the contraindications. Okay, reasons not to give a medication. Those are the harmful effects of something. Okay, now under contraindications, reasons not to give a medication, there's two kind of subcategories there. There's absolute contraindications, and then there are relative contraindications. Okay, we'll talk about this one a little bit later, but an absolute contraindication is to a medication like nitro. You guys will give nitro. If people have a blood pressure lower than 100, you are not allowed to give nitroglycerin. It will drop their blood pressures aggressively. We'll talk more about that here in a moment, okay? But that is an absolute reason. If we see that, we cannot give this medication. End all be all, that is it, okay? Then we also have relative contraindications. Now this one kind of shows up more, I would say, above your guys' scope, just because the medication lists get a little bit more encompassing, okay? But a good example would be at the medic scope, ketamine. Okay, we use ketamine, at least in the system I worked at, we used ketamine for induction into, or excuse me, pre-intubation sedation, essentially, okay? And then we would also use it for pain. Now, where it became a relative contraindication is one of them is head injuries, right? So, because ketamine is known to skyrocket blood pressures sometimes, okay? Well, if I have someone who hit their head and they're not breathing well, I kind of got a damned if I do, damned if I don't situation here, right? Because if I don't do anything to tube this person and give them a more secure airway, they're not going to last very long, okay? On the flip side of that coin, if I give this medication, I could potentially be doing damage to their brain, okay? It's a relative contraindication because you're going to have to make choices, and sometimes it's a tough one, okay? But it's not an absolute reason not to give something. And then we have adverse effects, so unintended effects or untoward effects, right? The medication is doing things that we don't necessarily want it to do, or it's a kind of a side effect, right? So like an unintended effect of nitro, for example, is it gives people headaches. That's a side effect of it. Now, I used to preface before I gave it to all my patients, this might give you a headache, it just means the medication's working, okay? So that would be an unintended or untoward effect. Questions so far? Cool. So let's go through some different names. Now, meds just generally have two different names, generic names or trade names. Okay, so generic names, simple, clear, non-proprietary. Okay, proprietary being the manufacturers who own like the rights to the name of the medication. So example would be like Advil, right? That's a proprietary name. But generic names, so this would be things like ibuprofen, okay, or acetaminophen, or naproxen sodium. Those are all going to be generic names, okay? On the flip side of that, we have trade names. The trade names are going to be the manufacturer's brand name, okay? Now, keep in mind, depending on who the manufacturer is, one drug can have multiple manufacturer names, okay? So for example, Tylenol, okay? Ibuprofen, Tylenol. Okay, or acetaminophen. Acetaminophen is not Aleve. I'm getting it mixed up with another one. Maybe it is. No, Aleve is naproxen sodium. Anyway, acetaminophen is going to be the generic name for, I'm blanking, it's bothering me. Anyway, where I'm trying to go with this, huh?
Isn't it for Tylenol?
You're right. Ibuprofen is for Advil.
Yeah.
I got it mixed up. Thank you. Yeah.
Wouldn't Narcan be an example of that? Because Narcan's really...
So yeah, not a bad one. So like Naloxone. So question was Narcan be an example of this? Yeah. So Naloxone would be the generic name. Narcan would be the manufacturer's name. Thank you. Yes. So Tylenol, acetaminophen is the generic name. Tylenol is going to be the brand name or trade name. Okay. So kind of for your guys' benefit, if you're going to go to places like Costco, right, buy the generic name. It's far cheaper. It's the same stuff. If you check the ingredients list, it's the same exact stuff, same dosing. Okay. Save yourself like 20, 30 bucks. Now, there are also different types of medications. You'll see these in all different variations, right? A lot of them could have trade names, a lot of them can have generic names, but there's prescription medications. Those are the ones that we tend to see the most with that back and forth, as well as over-the-counters. Over-the-counters being like the things you can buy, like Advil, Aleve, ibuprofen, those type of things, okay? Recreational drugs, right? We'll talk more about those in the next lecture today. But they can have their actual name, then they can have their nicknames, which we'll talk about some of those. Okay, there's herbal remedies, there's enhancement drugs, there's vitamins, and then alternative medicines. There's all sorts of different beliefs and viewpoints depending on where you are from in the world that can kind of give you kind of access or answers to what they think is a medication or not. Okay. That said, I would say things like Eastern medicine usually get kind of poo-pooed on here in our country. But if you think about it, they've been cultures for thousands and thousands and thousands of years. So maybe they kind of know what they're talking about. It's just a difference of opinion. Okay, but I digress. So Questions at all on medication names? Okay, so just understand there's going to be a bit of both. Now, we'll talk about it later, but I think one of the things that helped me the most when I was in paramedic school, I'm not expecting you guys to have this kind of same opinion on it, but one of the things that helped me the most is our professor basically gave us a quiz. He gave us 200 of the most commonly prescribed medications as well as over-the-counters, and then we had to be able to tell what that medication did. He chose 50 of those 200. What I'm recommending to you is maybe go through some of these meds. What are the most commonly prescribed ones? Okay, you're not gonna be quizzed on it, nothing crazy, but when you're out there and someone says, oh, I take atenolol, or oh, I take, no, I'll just stick with atenolol, right? I can be like, oh, that's a beta blocker. I know that's for your blood pressure, right? You can immediately start putting things together. Even if you don't necessarily know exactly what it's for, it'll help, okay? Like I said, it's just a recommendation, not a requirement. So do you. Now, routes. Routes are how we get the medication into the body. And there's a couple of different methods, okay? There's enteral medications and there's parenteral medications. So enteral medications enter the body through our digestive system. This is like taking a pill, as an example. Okay, then we have parenteral, which is having medications enter the body by other means. Okay, so things like IVs, right? They don't have to swallow that pill, we're putting it directly into their blood. Okay. Now, absorption, when we're talking about either one of these routes, but more so enteral, absorption is the process by which medications travel through body tissues and the bloodstream, okay? With common routes being PR, per rectum, and PO, per oral, or you'll see it as per os, per os. Either one is fine. They both mean the same thing by mouth, okay? Now, if we had to look at PR and PO, and then we go back to enteral, parenteral, enteral being digestive, parenteral other, what route type are these, enteral or parenteral? Enteral, right? They're gonna be enteral because they need our digestive system to be involved, okay? Now, just to give you guys maybe a little peace of mind, we don't give a lot of PR medications, per rectum medications. That's one we tend to see more so with like, in my experience, like rescue medications for seizures is a big one, but a lot of times it's with kids. They'll do per rectal medications. We do have that option at the medic scope. It's just not often used. There's other routes we'd rather use more often than not. So, common routes of administration: intravenous, IV, into the vein; intraosseous, IO, into the bone; subcutaneous, beneath the skin; intramuscular, into the muscle, okay? Has anyone ever had a TB test in here before? TB tests are subcutaneous. If you're gonna get a job on an ambulance or fire engine, you're gonna get a TB test at some point. They just put a little needle under your skin, they put a little fluid in there, make a little red circle, okay? And then they check it, I think it's 48 hours later. If that circle's gotten bigger, congratulations, you have tuberculosis. We'll talk all about that later, but you don't want it. You lost, I'm sorry. So, moving on with other routes. We have inhalation, inhaled into the lungs. We have sublingual, under the tongue. We have transcutaneous and transdermal, which means through the skin. And we'll talk about that a little bit more in the next one because there's a couple of, how do I want to say, misinformations that have been floating around, and I think they might give you some peace of mind with some stuff. And then we have intranasal, IN, that is a route you'll use as well. So if we're looking at these so far, IVIO, subcutaneous, those are all intrusive. Those all require a needle. Those are out of your scope. Now, intramuscular also requires a needle, but this one is gonna be in your scope. There's a certain medication that you'll give into the muscle belly. Anyone know what that is? Epinephrine, right? Like your EpiPens, they go into the thigh. We'll talk about those here in a bit. But yeah, those are intramuscular. That is in your scope of practice. Inhalation, you're gonna give an inhalation medication all the time. Any guesses on what that would be? Oxygen. Oxygen is a medication technically, right? We're giving a substance to help the patient and help them in their overall best interest, right? Sublingual will be a medication as well. You'll give nitro sublingually. And then intranasal is one of the last routes you guys will use. That's how we're gonna give Narcan. Okay, that's how Narcan is, the easiest way Narcan is administered. That said, it's not as controlled. We can give IV Narcan as well, and the situation looks a little different, but we'll talk about it here in a moment, okay? So our enteral versus our parenteral, okay? Our sublingual, per rectum, per oral are all enteral. They all require our digestive system to get involved, okay? Now for a study, hint, hint, wink, wink, if you know the 3 enterals, you'll know everything else is parenteral, right? Kind of an easy way. It's kind of a charting by exception or studying by exception type rule there, okay? Now, end of the day, you can see the rate here, right? So rates of absorption. You can see rapid, rapid, slow, immediate, rapid, moderate, slow, slow, right? It all depends on how fast that substance hits our bloodstream, which is why if we look at the immediates, there's only 2 on there. We have IV and IO. It's because we're dumping that medication directly into blood circulation. Okay, it's going to circulate and it's going to start, everything starts perfusing, those meds get dropped off with it. Okay? Okay. Now there's also different forms of medications you guys will see. The form of the medication, how it's packaged, how it's delivered is going to dictate the route more often than not, okay? Now, the manufacturers are going to be the ones who choose the route, or the ones rather, who choose the route. And that's just because, one, they're the ones making it, right? So they kind of know, they've been putting in the legwork, all the research, time, effort. This is the best way for this medication to be administered X, Y, Z. Okay, so the manufacturer chooses the form to ensure, one, the proper route of administration, making sure the timing of the medication's release into the bloodstream is good, right? We don't want to give something and it's going to kick in 45 minutes later, right? That's not ideal, especially in an emergent situation. And it also, they're going to help choose the form based on the effects on the target organs or body systems. What are we trying to affect? What are we aiming to influence? And what is the best route? Therefore, what is the best form to produce or manufacture this medication? Okay? And there's all sorts, right? We'll talk about a few of them here in a moment. But tablets and capsules, I guess. We'll talk about them now. Tablets and capsules, different, right? You probably have all taken probably both of these at different times. Okay, so capsules are gelatin-filled shells with powdered or liquid medications. These tend to be the long, stereotypical kind of ovally pill shape you guys are used to seeing that are like half blue, half red, and you can break them apart, right? Those are capsules. Okay, on the flip side of that, we have tablets. So tablets often contain other materials mixed, but they're compressed, mixed with the medication, but they're really tightly compressed. Okay, so like if you've ever taken Advil or ibuprofen, right? There's the liquid gels, which is going to be your capsule. Then they have the little orange pressed tablets, right? Little different. So tablets are going to be the teeny tiny pills. They've just a bunch of powders essentially smashed together until they hold their shape. Capsules are going to be gelatin filled with powder, liquid, depending on whatever the medication is. Okay? Questions on this at all? You guys will be giving tablets. You guys will be giving aspirin tablets. Okay, and we'll talk about the dosing of that later, but that's going to be one of the examples. We don't tend to give a lot of capsules, at least where I was working. You guys could potentially, depending on wherever you land, but we give tablets more often than not. Now the next types are going to be solutions and suspensions. Okay, so a solution, a liquid mixture of substances, will not separate by filtering or letting it stand, and then can be given as an IV, IM, or subcutaneous injection. Okay, this is going to be like epinephrine. When you guys draw up and administer your own epinephrine, that's one of those that if we were to leave that vial there, let it sit for days, months, years, don't let it sit for years, it'll get really gross. But if you look at it, it's not going to start separating. It's going to stay one clear fluid. Okay, that's a solution. Versus a suspension, a substance that does not dissolve well in liquids. Okay, so will separate if it stands or is filtered. Does anyone ever put a bunch of salt into a glass of water and then left it for an hour? And you look at it and all that salt's at the bottom? That was a suspension. It's not truly mixed in there to the point that you'll never see that salt again, right? It's a suspension, not a solution, where there's nothing going to be settling down at the bottom if you let it, leave it alone, essentially, let it be. Questions on these concepts at all?
You're not giving anything that's a suspension.
No, we don't give anything as a suspension at the basic level. One of the medications, there's a couple at the medic level, we give glucagon and then solumedrol, which is a steroid. They come separated, powder and fluid, and we have to reconstitute them and shake them up.
Glucagon does?
Huh?
Glucagon does?
Uh-huh, yeah. Glucagon comes in its own separate powdered vial, and then it comes with its own little saline vial. And you have to draw the saline out, put it into the powder, and then shake it up.
That's the only way it comes?
Is it what?
That's the only way it comes.
At least that's how it's come in my experience. It might come up processed other ways. But I don't know if that's for like a storage or management thing. There's factors in that as well. Yeah. Okay. Now another thing, meter dosed inhalers. Anyone ever seen these before? Right? This should be a very familiar looking object, an inhaler. So metered dose inhalers are liquids or solids broken into small enough droplets or particles that can be inhaled. Okay, so when you shake this thing up and you give it a puff, right, you see that little mist come out the end, that's gonna be your medication, but it's gonna be so small that you can actually inhale it, okay? Now, a meter dose inhaler directs these substances through the mouth and into the lungs, right? It's all about timing. We want you to shake it up till it gets nice and cold. You're gonna have the patient exhale all their air, put that in their mouth, form a good seal with their lips around the end, and then as they take a big breath in, you're gonna go boop, and you're gonna puff that into their mouth, right? They're gonna hopefully inhale all of that to their lungs, and it's gonna start working, okay? Now, the reason this is called a metered dose inhaler is because every time you press that button, it's gonna deliver the same amount of medication, okay? We don't have a metered dose inhaler necessarily that we'll administer, but nitro is a meter dosed spray that you will use. And we'll talk about that here in a moment. Does anyone know what medication normally lives in these things?
Respiratory support?
What?
Stuff for like respiratory?
Yeah, it is stuff for respiratory. Does anyone know the condition you would use this with?
Asthma.
Asthma. Yeah, you use this for asthma. This is albuterol more often than not. Yeah, albuterol sulfate. Okay. Now there's also topical medications, so lotions, creams, ointments. I'm sure you've all had experience with these to some degree or another, right? So lotions, creams, ointments applied to the skin surface, and they're only gonna affect what they're touching, okay? Now these are not the same as a transdermal medication. If we break down the term transdermal, what does that mean? What does that do? It goes through the skin. Yeah, transdermal means through the skin. These are not the same, these are topical. So these are only gonna affect what they're touching on the top, okay? So some examples, calamine lotion, right? For creams, hydrocortisone cream, and then ointment is gonna be Neosporin, right? I'm sure a lot of you guys have used Neosporin on cuts before. Yeah, Neosporin's one of the used for infections. Hydrocortisone is used for like rashes pretty frequently. It's got a very specific smell. I'm sure you've all had it on you at some point in time if you've ever gotten a rash and your parents were like, yeah, here you go, okay? But different things, we don't use any of these, but these are things that we might have to consider, right? We don't know what necessarily is on the patient's skin, okay? I don't know necessarily there'd be anything incredibly harmful with these unless they're allergic to them, but I could be wrong. That's just in my experience. So, we also have transcutaneous medications. So transdermal, transcutaneous, tomato, synonymous. Okay, designed to be absorbed through the skin. Now, these can have systemic effects. To that same point, if you touch a transcutaneous medication, it can affect you as well. Okay, it can absorb into your skin just like the patient's. Now, one thing about these transcutaneous, transdermal medications is that often that it's how they're usually patches is how we see them, unless it's going to be like an ointment or a cream. I guess there is one that's a paste that we will use. It's nitro paste, causes systemic, but I digress. These patches are designed, there's a chemical in there that makes them transdermal, transcutaneous. So an example would be fentanyl patches. Fentanyl patches are used pretty frequently for pain control, especially in older folks, okay? That said, we'll talk about this later, fentanyl as a medication, or rather as a drug, is not transdermal. It is not transcutaneous, despite the videos you may have seen. We will talk about them, okay? For something to be a transcutaneous medication, Depends on the med, but for the most part, there has to have some sort of chemical involvement to make it transdermal, transcutaneous. Okay? Questions on this concept at all? Okay, just remember transcutaneous meds, they're actually going through your skin and entering the bloodstream that way. Okay, it's not enteral, it's a parenteral route. Okay. Now another one you'll see is gels. Semi-liquid, administered in capsules or through plastic tubes, with the example being oral glucose. You guys will give oral glucose. What type of patient do you think is going to be using oral glucose? Diabetes, yeah, exactly right. Now, here's your first dose, okay? Now, when I say the doses, I'm going to give you a range of numbers, and I'm also going to tell you the unit of measurement. Make sure you're writing that unit of measurement because it makes a difference, okay? So our dose for oral glucose is 15 to 45 grams. You can just put a lowercase g next to it. 15 to 45 grams, okay? Now, this is the type of tube that my agency used to carry. Nowadays, they kind of look like, if anyone's ever seen those goo packets that runners do, that's kind of what they look like now, or at least just that manufacturer. Now, I know I said 15 to 45 grams. This tube here holds something like 37.5 grams. So if we're gonna give that, what do you think how much of it you think we're giving? The whole thing, right? If there's 15 to 45 grams is our dose, that holds 37. Let's give the whole thing, okay? And we'll talk about it. It'll make more sense when we get to diabetes down the road as well, okay? We're just introducing the meds right now. Now, we also have gases, right? So usually delivered through non-rebreathing masks or nasal cannula, which i.e., if you haven't put it together, oxygen. That's going to be our medication we're talking about. And then outside the operating room, we don't really use much besides oxygen. Okay, someone ever had their wisdom teeth taken out before? Got the nitrous oxide, right? The feel-good gas makes people act a fool afterwards. There are agencies across the country that are actually using that for pain control. I asked about it one time, and they basically said that the storage is really difficult, finding the proper storage methods. So it was not one that we saw coming to us very quickly, but it does happen. Now, this is also, if we think about those oxygen canisters and our regulators, right? There's the two extra little upside down holes there, right? When we put the regulator on, that's part of the pin indexing. Okay, and the reason we put those on there is so we know, okay, this regulator only lines up with oxygen. We're not putting it on nitrous oxide by accident. That has a different pin indexing setup, okay? Okay, now, when it comes, or any questions, I guess, on our types of medications we'll see. Okay. So, general steps for administering a medication. Okay, so medication should be administered only under the authorization of medical control. The medications that we will talk about are now all in your scope of practice. Okay, you can draw up and administer epinephrine as needed now. Okay, let's keep that in mind. Now, like I said earlier, people get nervous with medications because it's one of those things, we're giving someone something that might influence their overall health, maybe negatively if we do it wrong. Now these rights, you'll see these rights of medication administration. Okay, there's going to be 6 of them in particular that we care about. If you follow these 6 rights, you're probably not going to have an error. You're probably not going to make a medication mistake. Okay, it's kind of our double checking. Okay, so for example, this is a concept that was stolen actually from airlines, because airlines were one of the first kind of industries, I'll say, that actually started using checklists before they take off for a flight. Okay, that's good, check, that's good, check, right? Same idea. By going through these 6 rights, we can make sure that we're not giving the wrong medication for the wrong reasons. So the 6 rights that we care about, the right patient, okay, we want to give it to the right person. We have the right medication and indication, right? We're giving the right medication for the right reason. Okay, we're giving the right dose, giving the proper number. We're giving the right route, making sure, is it PO? Is it going to be PR? Is it subcutaneous? Is it sublingual? It's going to make a difference. Are we giving it at the right time? Okay. And then the last one that we're going to include, We're going to skip a couple if you're looking at this list. We're going to go to right documentation. Okay, make sure you're charting everything. Because obviously we want to make sure we have the right education. We want to make sure we remember the patient has the right to refuse medication administration. And then obviously we want the right response depending on what we have. Those are kind of givens. So right patient, med, dose, route, time, documentation. Those are the big 6 that we care about. Okay? And remember, when it comes to documentation, if you did not write it down in the eyes of the law, it never happened. Okay? Questions on the rights? Okay, moving on. So, medication administration and the EMT. So, circumstances in which medications may be administered. There's going to be peer-assisted administration, patient-assisted administration, and then EMT-administered medications. Okay? Peer-assisted administration, oftentimes that's going to be more patients, right? Patients have their friends help them out with their meds. I've seen that one go south a couple of times, so if you're one of those people, maybe make sure you're paying attention to when they're talking to you. But that's one we'll see a lot of the time where, like, if someone has an EpiPen and their friend sees it and they're having an allergic reaction, their friend can stick them, okay? Now there's also patient-assisted administration, right? We can coach them on how to do this, okay? So for example, albuterol, right? If they have their inhaler and they're like, I'm not sure how to use it, we can teach them how to use that, okay? And then we have EMT-administered medications. These are the ones that you're just going to give yourself, right? Here, take these aspirin. Here, open your mouth, I'm gonna give you a spray of nitro, okay? I'm gonna start a nebulizer. Let's get an albuterol neb going, okay? Now, these are gonna be determined by your state and local protocols as well as medical control. Okay, now medical control, remember, can allow you to deviate from your scope. So if you call them and you're like, hey, I'm not sure what to do, and they say you should give X medication, and you say that medication's out of my scope, as long as it's administered properly under medical control order, you can give it as needed, okay? But let that medical control situation guide itself. Okay, does that make sense? Okay. So some oral medications. Confirm that the patient has a patent airway and is able to swallow, and then instruct them to swallow or chew it, depending. The aspirin we give is chew and swallow. Okay. Why do you think we need to make sure they have a patent airway? What are we doing if they don't have a good airway and we give them pills? Yeah, we're just making an obstruction. It can get stuck in their throat, right? We got to make sure that they have the ability to swallow, okay? And that we'll kind of talk about another medication or oral glucose again. That's going to be one of the big parts of that, okay? And that can be kind of tricky because sometimes they get a little bit less than conscious. Okay, so oral glucose, a sugar that cells use for energy. We use it to treat hypoglycemia. That is our indication, okay? You guys will give this orally, so by mouth, and then we will not give oral glucose to anyone unconscious or anyone who cannot protect their own airway, okay? If you show up to a hypoglycemic patient who is unconscious, you're gonna need to contact ALS, okay? ALS has a more invasive way to raise someone's blood sugar, okay, via IV. For you guys, you only need to worry about oral glucose, okay? But once again, if they are not alert, they can't swallow, they don't have an intact gag reflex, we are not going to give them oral glucose, okay? And then once again, our dose, 15 to 45 grams, which half the time is just the whole tube, okay? Questions on oral glucose at all? Cool. The next one, aspirin. Aspirin's job reduces fever, pain, and inflammation, okay? Aspirin is an antiplatelet aggregation inhibitor, okay? So it basically stops platelets from clotting up. Now, we use it, our indication is potential heart attacks. That is the only time that we will administer aspirin, okay? Now, a lot of times a common mistake I see is people say aspirin's a blood thinner. Blood thinners make you bleed, right? It's not a blood thinner, it's different. Blood thinners, examples like Eliquis, okay, or Plavix, they make it so you don't clot at all. What aspirin does is if you have an existing clot, it stops that clot from getting worse. okay? It just makes it so instead of being sticky, those platelets kind of bounce off the clot, okay? But they do not dissolve clots. Yeah, correct. Yeah, the question, do they dissolve clots? They do not. The medications that dissolve clots are what we call thrombolytic medications. Like TPA is an example we'll talk about when we get to strokes. Now, with aspirin, there are some reasons we cannot give it. First one being hypersensitivity. What do you think hypersensitivity means?
They're sensitive to it.
They're what?
They're just sensitive to it.
They're sensitive to it? What's another way we could say it? They're allergic to it. Yeah, sorry if you said and I didn't hear you out. Deaf, you're quiet, I'll say it. Yeah, if they're allergic to it. So I'm gonna tell you, if you advance your scope and you start doing other medication, exams, benchmarks, tests, whatever you wanna call them, either at the advanced EMT or paramedic scope, more often than not, if they ask you, what's a contraindication to this med, and you say hypersensitivity, you're probably not gonna get the point because they're gonna say, no shit, don't give people stuff they're allergic to, right? If they tell you, I'm allergic to aspirin, maybe don't give that to them, right? It's pretty obvious. Now, other ones, if they have liver damage, because aspirin is processed by the liver, that's one of the ways it's filtered out of the body. It can be pretty hard on the liver, okay? So if they have a bad liver, that can be one of those contraindications. Bigger one, hint, hint, wink, wink, that may show up in a couple of weeks, bleeding disorders, right? If they have a hard time clotting already, we don't want to give them something that's going to make their ability to clot harder, okay? Asthma's on this list as well. Not entirely a fan of why, we're not going to talk about it, but should not be given to children as well. So we do not administer aspirin to anyone under the age of 18. Reason being is there's a thing called Reyes syndrome, R-E-Y-E-S. Reyes syndrome. Reyes syndrome essentially is a congenital disorder that we don't know if the kid has it or not. That's why it's under 18, we don't give it. But if you give them aspirin, it can cause massive brain swelling, essentially. Okay, it's what we call cerebral edema. They start getting a swelling in their brain, which is obviously problematic if we remember what happens to our brain if we put pressure down. Now, these come in individual tablets. Each individual tablet is 81 milligrams. One total dose for us to administer is 324 milligrams. That's your dose per oral or per os. 324 milligrams, mg, okay? Which is just 4 of those 81 milligram tablets, okay? That's how you can tell someone's been doing this job for a while, right? Versus school. In school, half the time is, hey, what's our dose of aspirin? And they say 324 milligrams. And then you walk up to anybody out on the street and say, hey, what's our dose of aspirin? They'll say 4 of those bad boys. Same thing, right? 324, 4 81 milligram tablets. Okay? Everyone got that? That's the second med. So indications, heart attack. Contraindications, bleeding disorder under the age of 18, liver damage, hypersensitivity to aspirin, right? Allergies. Now, sublingual. If we use med term, what does sublingual mean? Yeah? Under the tongue. Yeah. Now, there's some advantages and disadvantages to this. Okay? Advantage, it's easy to advise the patient on how to use it. We tell them put their tongue on the roof of their mouth and we spritz it under there. Or if it's like a pill, if anyone's ever taken Zofran, which is an anti-nausea medication, you have a question or you're just stretching? If Zofran's an anti-nausea medication, they'll put under the tongue and it'll melt. I'm sure some of you guys have taken that before. There's all sorts of different meds that'll do that. Those are all sublingual, okay? Because you have, basically you have, what's the word I'm looking for? Your mucous membranes in there that'll be absorbed through those, okay? Now, another advantage, it's quick and absorbed pretty fast. Disadvantage, we're gonna have to constantly evaluate the airway, right? If it's something where it's a pill that dissolves under their tongue, it's gonna take a while, potentially. We gotta make sure they're not choking on that, right? So possible choking. And then not for uncooperative or unconscious patients. We're not gonna give this to unconscious patients. Uncooperative because we can end up missing our spritz, okay, more often than not. Now, unconscious, we'll talk about it with nitro. That's gonna be our sublingual medication of choice, or the only one we give sublingual. We don't give that one to unconscious people because one of the effects of nitro is hopefully they get some pain relief. Well, if they're unconscious, are they gonna be able to tell us they feel better? Not really, right? Because they can't talk. So keep that in mind, right? Nitro is one of those we want to make sure we can get responses. We don't use it on unconscious, unresponsive people. So nitroglycerin, its job, it relieves angina pain. We'll talk all about that in about 2 weeks. Okay, but angina is heart pain. Okay, it relieves heart pain. So we use this for suspected myocardial infarction, suspected heart attack patients. Okay, its job is to increase blood flow, which we'll talk about more, but it does this by relaxing veins. Nitro is a vasodilator. Okay, so it opens up veins. In particular, it's a vasodilator for these arteries and veins, okay? The ones on the heart itself, okay? It'll make sense. We'll talk about it on Monday when we have our med administration day. Tuesday, you're right. Thank you. But yeah, basically what it does is it relaxes the heart's vasculature so it's circulating more blood so the heart's not working as hard. But we'll talk about it, okay? It'll make more sense, like I said, on Monday. Now our dose of nitro, 0.4 milligrams, with our route being sublingual, or SL, okay? The one we use more often than not is this handy dandy little orange bottle right here, okay? We don't really give nitrostat, which is gonna be the pills. That's more often than not prescribed to people who have had heart attacks in the past. Either they're gonna have something like that, or in my experience, they have a little silver bullet as well that they kind of wear. Yeah, Bryn.
Is it within our scope if they have their prescription with them, they're talking us through and like, yeah, I have my nitro on me.
Mm-hmm.
Can we help them take the pill kind if it's their prescription?
Yeah.
Do you check right patient, right med, right dose, right time? Right?
Yeah. So question, can we help the patient administer their own pills? Yes, we can. If they have them, we can use that in lieu of, because I believe the pills are slightly different. I think they're 0.3 milligrams, so just slightly different. But we can help them if they're prescribed it for sure. And then on the bottle, it'll have their name and we can verify the prescription's theirs. And as long as it's not expired, we're good to go. Yeah, Bryce.
So you mentioned the silver bullet. Is
Mm-hmm.
it like, what is it?
It looks like a silver bullet. It's just a little pill bottle essentially. They wear it as necklaces more often than not.
And for the administration, you said we'd see the spray more than the pill.
Mm-hmm.
Correct?
Yep, we will see the spray more than the pill.
0.4 is just one.
Mm-hmm.
Okay.
Yep, so this isn't a meter dosed inhaler, right? Because they're not breathing it in, but it is a meter dosed spray. So when we administer this, we'll talk about it again on Monday. The first thing we do is we spritz one to the floor, we prime it, make sure there's no air in that line. The next thing we do is one spritz under the tongue. It's gonna be 0.4 every time. Okay, good questions. Okay, so nitro, oh yeah, Bryn, go ahead. This is,
Never mind.
just refresh, okay.
Yeah, I think you're getting to it.
Okay, so there are some caveats to nitro, right? So before administering, we have to check a blood pressure. They have to have a minimum blood pressure of 100 systolic for us to administer nitro, okay? Nitro can drop blood pressures aggressively, okay? I would even say personally, I know 100 is gonna be your NREMT answer. Personally, if I'm at like 105, 106 systolic, I'm probably not gonna give it. I'm gonna think about it a little harder. As a medic, I never administered nitro until I had an IV on the off chance I dropped their blood pressure. I've literally dropped people 15 points off one spray of nitro systolically. Okay, it can be pretty aggressive. So we gotta check the blood pressure, minimum being 100 systolic. And then it says obtain order to administer. This is in your scope. Now here's the realism of this, is if we are administering nitroglycerin, the likelihood of you running this whole call is very, very minimal, right? At least in this area, you're never by yourself as an EMT basic. You're gonna have an ALS paramedic provider with you. If it's a chest pain call, they got EKGs, they got all sorts of other stuff to do. Your job though is gonna be to know how to administer this. I can't tell you how many times I'd tell my EMT basic, hey, I'm gonna get this EKG rolling, I'm gonna get an IV started, give them a spritz of nitro for me, okay? Because I know you guys can do it because it's in your scope, okay? Now we use it for MI, right? We're hoping that we're gonna hopefully relieve some of this heart attack pain. Now, another contraindication, so first big contraindication, less than 100 systolic. The next big one is if they're using erectile dysfunction medications, ED meds, so Viagra, Cialis, okay? Reason being, fun fact, Viagra was initially designed and was being manufactured as a blood pressure medication, just had a way more marketable side effect. So they decided to kind of switch gears with that one, okay? There are patients who are prescribed Viagra for blood pressure, okay? So before we ever administer nitro, we have to ask, have you taken any erectile dysfunction medications in the last 24 to 48 hours, okay? Because if we think about it, right, an erectile dysfunction medication is gonna drop their blood pressure. If we give them nitro on top of it, we're gonna double up what we're dropping, right? Yeah, question, Bryce? Got it, cool. Yeah, so we gotta ask 24 to 48 hours. Now, you're gonna have to ask this to everyone, females included, okay? I had one patient in particular, I sounded like such a dummy, is the word I'll use for this one, but this lady had chest pain. I was like, oh, kind of facetiously, any chance you're taking Viagra? She's like, yeah, I'm taking it for my blood pressure. And I was like, oh, well, foot and mouth, I stand corrected, right? You're gonna have to ask it to everybody. It's not just for the extracurricular activities, okay? Some people will use it for blood pressure management. And then, like I said earlier, one of the side effects, it can cause a headache. It's kind of one of those things that it can cause. For those of you who have ever been hung over from wine, a wine hangover, you get a headache the next day, it's because of the nitrates in the wine. Nitro is made of nitrates, okay? Now, administration by tablet, it's gonna go under the tongue. It also might cause a slight tingling or burning. And then, like a lot of our meds, nitro in particular, storage is important. When I was saying they're in a silver bullet looking deal, it's because that gets all light out of there. It also helps to keep the temperature manageable. We can't have it getting too hot or too cold, because otherwise it'll do what we call denaturing, if you've ever taken chemistry class. So when basically molecules and chemicals stop working effectively because of one reason or another, temperature being a big one, okay? Now, like I said, we don't typically give tablets. We can assist the patient if they have prescribed tablets. More often than not, we use our own little spray, that orange bottle, okay? It's gonna be on or under the tongue, and one spray is one tablet. So I used to ask them, just put your tongue on the roof of your mouth, spritz it to the floor, spritz it right under their teeth, onto the lower tongue, okay? Or over their teeth, under their tongue. And that would get you your nitro, okay? Now, some things we gotta consider. If it's gonna drop blood pressures really aggressively, do you think we wanna give them a lot of doses really quickly? Probably not, right? So you gotta wait at least 5 minutes before repeating a dose, but you can repeat nitro, okay? Make sure you're monitoring vital signs. Make sure you're wearing gloves. This is one of those that can be transdermal, so if you get it on your skin, you can drop your blood pressure. If you're standing up and you drop your blood pressure really aggressively, what do you think happens to your mentation? Goes down, right? You're gonna pass out more often than not, okay? But know your protocols. Wherever you land, they could do some things that are slightly different, okay? At the Medic scope, we also use nitro paste. So it's literally a tube of nitro, and our dose is 1 inch to 1.5 inches. They give us a sticker with a little ruler on it. So there are other methods that we will use this for you guys. That's not really an option, okay? Questions on nitro at all? Okay, moving on. Intramuscular meds. So advantages, it's quick, easy access without using the vein. And our muscles have stable blood flow, right? We gotta keep those muscles alive via perfusion. There are some disadvantages though. We gotta use a needle, which typically is not the biggest deal unless we have someone freaking out, right? Then we got a needle out and about, and if we got a room full of, an ambulance full of people, that's a lot of people, tight space, one big needle makes a difference, okay? It also is gonna cause pain. So if we think about kids, right? Kids having an allergic reaction, kids don't like needles. They're gonna panic with that. We're gonna have to kind of overcome that with them, okay? So patients may fear pain or injury as well from the needle. Now, one of the nice things, it's quick, easy access without using a vein, and we have stable blood flow. What does that mean for medication entering our system, do you think? It's gonna be fast or slow? It's gonna be pretty fast, right? Because it's gonna enter our bloodstream pretty quick. It's not like when we eat it and it's got to dissolve for 30 minutes and then it starts showing up, right? We're going directly into the blood supply. Well, not directly, but pretty close. So our medication of choice for IM, epinephrine. You guys can administer, draw up and administer epi. Okay, so epi, once again, fight or flight response, with our primary route being IM. Epi is given all sorts of routes above your scope. Just keep that in mind. And that's also called adrenaline, right? So adrenaline, epinephrine, they're the same thing. Now, epinephrine is known as a sympathomimetic when we are giving it, okay? What does the word mimetic kind of remind you guys of? Another word for copy. To mimic, right? Sympathomimetic means it's mimicking our sympathetic nervous system, right? So when we administer epinephrine, we're trying to replicate your fight or flight response, okay? Now this is the only medication that I'm going to require you remember the pediatric dose, okay? So the adult dose of epinephrine, 0.3 milligrams IM. 0.3 milligrams IM. Our dose for pediatrics, 0.15 milligrams IM. Notice that I'm emphasizing the 0, okay? Ambulances, fire engines, they're loud pieces of apparatus. If you say, hey, draw me up 0.3 of epi, and they don't hear the point, and they draw up 3, and you're not paying attention to your dose, and you administer that, you can do a heck of a lot of harm to that patient, right? Especially if they have a cardiac history.
Pediatric is
0.15.
So
Yep.
Really, toddler.
Say that again.
Toddler or if less than 8.
Kids less than 8. Kids less than 8, yeah. The dose can kind of adjust as they get younger. So like EpiPens, for example, those are going to be pre-dosed to the same thing. So adult 0.3, pediatric 0.15. Both milligrams, both IM. Questions on epi at all? Okay. So what does it do? It increases heart rate. It constricts blood vessels. Those are going to be a bit of both beta 1 and alpha responses, right? Increasing our heart rate, which another thing it does is it's what we call a positive inotrope, meaning it increases the contractility. So every time your heart beats, it makes it stronger, okay? And it constricts our blood vessels. There's the alpha response. If we're constricting blood vessels, what's happening to our blood pressure, hopefully? If we constrict our vasculature, what does it do, Paige? It goes up, yeah, very good. And then may be delivered with an auto-injector to treat life-threatening anaphylaxis, right? EpiPens. I skipped a bullet, I'm gonna come back to it. So, we do not give to patients with hypertension, hypothermia, heart attack, or wheezing. Wheezing, I've got caveats to that at the medic scope, but digressing. Hypertension, right? If their blood pressure is already high, we don't wanna give them something that's gonna raise their blood pressure, right? Pretty sensical. Hypothermia. Now, when we get cold, as some of you probably read in the environmental chapter that I'm sure every single one of you read so thoroughly, right? But as our body gets cold, our heart gets kind of finicky, gets a little overreactive, right? Remember we were talking about if we jostle people who get too cold, we can throw them into cardiac arrest? Same thing, if you give them epi while they're cold, you're basically increasing the workload of their heart. Well, their heart's already kind of pissed off. So you can actually end up throwing them into abnormal heart rhythms, okay? And then kind of the extension with MI, with heart attacks there, myocardial infarctions. If there's a clot blocking vasculature in the heart, and the heart's already working hard to try and compensate for that, we don't want to make the heart work harder, okay? But like I said, we'll talk all about MI later. Now, for you guys, the only time you're going to give it, our indication, is anaphylaxis. IM 0.3, 0.15, as needed, right? Anaphylaxis. As far as contraindications go, there are contraindications as far as, obviously we don't want to give it to hypertension, heart attack folk, but absolute contraindications, there are none. There are none in life-threatening anaphylaxis or cardiac arrest. Okay, that's literally going to be your answer on your pharmacology benchmark. Okay, there is no contraindications in life-threatening anaphylaxis or cardiac arrest. Epinephrine is a cardiac arrest medication we use frequently. Now, we'll talk about it a little bit Monday. The epinephrine you guys will also be giving is a ratio of what we call 1 to 1,000. 1 to 1,000. So it's 1 milligram in 1 milliliter of fluid. Okay. Cardiac epinephrine is 1 to 10,000. So 1 milligram in 10,000, in 10 milliliters of fluid. A little different. I'll show you what those boxes look like. Think about like the tiny little medication vials. That's the one you're thinking, or you're going to be using for the most part. Okay.
But we don't need to know that.
You don't need to know that. I would maybe remember 1 to 1,000 though. That might be worth your time. Oh, go ahead.
Ratios for which thing?
So 1 to 1,000 is for anaphylaxis epinephrine. Yeah, very good. You have another question, Bryn?
Yeah, what was the word you said? It's a positive.
Inotrope. INOTROPE. That's a fancy word we use for the heart. There's inotrope, dromotrope, and chronotrope. So dromotrope is the electrical currents, and then chromotrope is the timing, right, the rhythm of it. And then inotrope's contraction. So all of those in conjunction form heart functioning, but you don't necessarily need to know it at that scope. It's just fancy words we like to say. Okay, any questions on epi so far? Okay, moving into our next medication. We can give this one IM. We typically don't though. Okay, but naloxone. Naloxone has one job. It replaces opioid chemicals on mu receptors. Okay, so we use it to reverse the effects of opioid overdose. Now, some considerations. Consult medical directions. Understand the effects may not last as long as opioids, so we might have to repeat. I'll come back to that. It can cause severe withdrawal, and then consider your own safety. So, Narcan, we only use indications for opiate overdoses. Narcan we only use for opiate overdoses. That is our indication. As far as contraindications go, there's not a lot. The reason being is that Narcan doesn't do anything to you if you haven't taken opiates. I could give Narcan to every single one of you in this room, and it's not going to do anything unless you're secretly taking opiates, in which case, maybe rethink some life choices. But, okay, we can still give it. Okay, so our dose for Narcan, 0.4, I digress, 2 to 4 milligrams. 2 to 4 milligrams. I got it mixed up. 2 to 4 milligrams, and our route that we're going to give is IN, which we'll talk about here in a moment. Okay, now, the second bullet here, effects may not last as long as opioids. Depending on what people are using out on the streets, it can be pretty potent, okay? To the point that we can give them Narcan, and Narcan's gonna kick those opioids out of those mu receptors, but it's not necessarily gonna get rid of those opioids. They're still gonna be hanging out and floating until eventually that Narcan wears off, and then they can go right back to where they were, okay? So, Narcan a lot of times does not last as long as the opioid. There's other things we also have to be really considerate of with Narcan, is things like what we call polypharmaceutical, which is going to be a fancy word you're going to have to write. Promise that's going to show up on your benchmark. Polypharmaceutical, okay? What do you think polypharmaceutical means? What's poly mean? Multiple. What's pharmaceutical, you think? Medications, so putting it together, multiple meds, right? A lot of times, this is kind of still in favor, but it was more so back in the day with heroin. But heroin and meth used to be mixed together. They used to call that 8-balling, right? So if we give someone who overdosed on an 8-ball a bunch of Narcan and we take away all that heroin, what's left in their system? That methamphetamine if they took both, right? So they're going to go from 0 to 1,000 really, really fast. Okay, so polypharm can be something that we have to be kind of considerate of. If we're going to take away all of the opiate in their system, what else do they have in there that could potentially get a response? Okay. Now, like I said, our dose is 2 to 4 milligrams IN. Okay, if we're going to give 2, we're going to do 1 per nostril. If we're going to give 4, we're going to do 2 per nostril. You want to keep them balanced. Okay, 1 in each nostril, 2 in each nostril. If you give too much Narcan at one point, you're not necessarily going to harm the patient, but they are going to get up and they're going to go into withdrawal symptoms, meaning they're going to get up, they're going to puke, and they're probably going to swing at you, okay? That's why you got to consider your safety. I was reading about in cities like Portland right now where fentanyl epidemics are going crazy, that parents are actually training their kids to administer Narcan on the walk home, like to walk to school. And I have mixed opinions on it. Do I agree as a humanity perspective it's a good idea? Sure. Do I think it's rationally as someone who's seen opiate addicts get up and try to harm people? I don't think it's a good idea from that perspective, okay? I'm not here to make the laws. I'm not here to influence your opinion one way or the other, but those are things you have to consider, okay? And then one demographic in particular that loves to give a lot of Narcan, in my experience, has been police. It's one of the few medications they can give on the off chance it is a overdose of opioids. To the extent the last time I had an opiate overdose patient, when I showed up, I asked how much Narcan they gave this poor girl, and they said 16 milligrams. She got up, puked, felt like garbage because she was in withdrawals immediately. They overdosed her super, super hard with it. Okay, it happens. That said, they're not necessarily going to die because they gave so much of that medication. It's just that they're not really doing a service to the patient either, right? That's not acting in the patient's best interest necessarily, okay? Questions on Narcan? Yeah, Bryn.
If you do have a
Farm.
pharmaceutical situation with Naloxone,
Mm-hmm.
is there like a contraindication for like that?
Yeah, so is there any contraindications?
You just have to deal with, like they're swinging the other way.
So if there's contraindications of polypharm, not really. The thing that we can consider is our dose, right? Maybe we give them a lower dose and we taper that. At the medic scope, we can give Narcan IV. Your guys' dose is 2 to 4. I used to start with 0.5. That would be enough to get them breathing again, but less likely they're gonna get up and swing and puke on me. So you can cater in your dosing. Depending on where you work, right, it can be specific kind of towards your protocols though. So keep that in mind.
When you give the dose to like if you wanted to do 2 milligrams, that's one in each nostril?
Yep.
One milligram per.
Yep, 1 milligram per. Now Narcan is also an over-the-counter as well. So this is one that you'll see more frequently. I checked, it's at Walmart, it's $40 a bop for a box of 8 milligrams. I will have a couple of practice ones. I've never used them. They rolled out into the field after I left, so I never got the chance to actually play with one in the field. But I have simulators that you guys will all see. Yeah, Paige.
And is it the same dose regardless of it's like intramuscular versus?
Yeah, for the most part. It's just we're not going to be giving intramuscular meds. Yeah, it'll be, or at least we won't give this one intramuscular. This is intranasal, which if you think about perspective-wise, right, I hope you guys have not spent a lot of time around, opioid situations. But a lot of times, right, if they're on the side of the road, they're dirty, I'm not going to take the time to shove a needle in their arm when I can just spray it up their nose. It's a lot easier access.
If you've got 8 milligrams as your amount of meds in the thing, is it kind of one and done?
You can spritz it twice for what I've heard. So you can do 4 and 4. Yeah, you're going to be hefty dosing them, which is why another reason when I was saying they're training kids to do this, they're training kids to give hefty doses of this to people.
Or let's say I just used 2 milligrams.
Yeah.
Then I got 6 more.
I don't think it's that specific. I don't think it'll let you be like dosing that specifically 2 at a time. It carries 8 total, and I think it'll only let you administer 4 at one go, like per spritz. It's not one like we're giving with the syringe where you're pushing slow 1 at a time. It's I'll show you. It's kind of like a U shape with a nose piece in it, and you just push the button. Once it will get the 4, and then the second time we'll get the other 4. But you can't do 2.
So if I do 1.
Yeah. So if you push the button once, you're going to give 4.
What if like we call it good? Then is that trash at the end? I guess that's what I'm asking. If you have a half dose left in.
I would hold on to it. Only reason I say that is opiates can outlast our Narcan. Right. So they can go back into overdose, then we have it if we need it.
If that falls over, then that's trash.
Oh yeah. Which we don't use those. We draw it up and we have syringes we'll use. Yeah. Way more effective methods. Yeah, Bryce.
So on a BLS ambulance, do we have the actual like nasal?
Yeah. Well, I would assume. I've never been on a strictly BLS rig, but it comes prepackaged, and I'll show you what that looks like. Cool. Okay, so intranasal, right? We talked all about it. This is Narcan. So most common technique is going to be our intranasal route, just because it's easier. So this is how it's actually going to be packaged and how you guys are going to use it. Okay, this is what's called a pre-filled syringe. Excuse me. And it's going to come, I believe this one has 4 milligrams in it. Basically, it comes with a vial full of fluid, right? It's not going to be a suspension, it's a solution because it's not going to settle. And it's going to come with a little administration piece. You're going to screw that in there. And then this little thing that's in his nose is what's known as a MAD, M-A-D, or a mucosal atomizer device. And you guys will see what it does. When you spray a syringe, I'm sure some of you have seen it, right? It's just going to shoot that squirt of water. What that does is it makes a mist, creates a fine mist. That way we're going to hitting more of the nose and we're hopefully administering more of the meds. Because in our nose, just like our mouth, we have mucous membranes that can absorb this into our bloodstream. Okay? And then 2 to 4 milligrams IN is our route, which we will repeat, this is important, every 1 to 4 minutes. Repeat IN every 1 to 4 minutes. Hint, hint, wink, wink, that may or may not show up. Questions on Narcan?
Every 1 to 4?
Every 1 to 4, yeah, 1-4 minutes. Okay, and then inhalation meds, right? So oxygen, we've talked all about it, right? All cells need it to survive, which we will generally administer through a non-rebreather mask or a nasal cannula. What's our flow rate of oxygen for a non-rebreather? 10 to 15. What's our nasal cannula rate?
0 to 6.
What?
Is it 4 to 6?
Not 4 to 6, 1 to 6. 1 to 6. Now, most of the time, most regulators don't go to 1, they start at 2. I have seen regulators that start as low as 0.25, but 1 to 6 is nasal cannula, 10 to 15 is non-rebreather. What's our BVM? 15. If you're gonna use the BVM, the most extreme breathing apparatus we have, we want the most oxygen. Yeah.
I know we kind of passed that with the last benchmark, but what's the 0.25 oxygen? Would that just be for like a slight miss?
I have no idea. I have no idea why someone would justify using 0.25 of oxygen. It doesn't make sense to me. That's why most of them start at 2. Okay. Yeah. I've never, that was when I was in Washington with another agency. I've never actually used one. Okay. Yeah. Okay, so this is another one we will use, MDIs. So MDIs and nebulizers, right? Like I told you earlier, we don't carry the inhalers, but we do carry nebulizers, okay? So nebulizers are liquids turned into a mist or spray, and the medication is breathed in and hopefully delivered to the alveoli. Now the nice thing about them is they're absorbed pretty fast, okay? Because we're going directly to the root of the problem. And it's an easy route to access. Nice thing as well is it's portable, okay? Now, do you guys remember what medication lives in those MDIs?
Albuterol.
Albuterol, yeah. This can be the same thing for a nebulizer, okay? Now your dose for albuterol in the nebulizer is 2.5 milligrams. Nebulized is our route, okay? 2.5 milligrams nebulized. You'll notice on your drug sheets for your pharmacology benchmark, that is going to be the highlighted one. I don't necessarily care about the meter-dosed inhaler dose. What I do care about is your nebulizer dose. That will be a question you're going to be asked. Okay? Now, you've also heard oh yeah, Carter, go ahead.
What was that one for?
Albuterol. 2.5 milligrams, yeah, albuterol. You guys have heard my opinions before, but I'm going to talk about it again. I hate this T piece. I really am not a fan of how that's set up. Reason being, if I have to ask somebody questions and they've got that thing in their mouth, 1, they can't talk to me. 2, a lot of the time people, as they're trying to take it out of their mouth, they're like holding it sideways, dumping my medications out, not being helpful. So, nice thing is you can actually pop this little canister out here, and then you can pop the bag off a non-rebreather. And that canister will fit into the non-rebreather where that mask is. And then it's the same process. You're just gonna nebulize that up, okay, and it'll start flowing. Now, there is a certain flow rate of oxygen you're gonna need to nebulize a medication, okay? And it's starting at 6 to 8 liters. You can start nebulizing a medication at 6 to 8. Anything north of that will also nebulize, okay? You're just gonna be using more oxygen, obviously. So there are times, say you have a really bad asthmatic, their SpO2 is super, super bad, you wanna give them a non-rebreather at 15, you can do both at the same time. You can nebulize albuterol and give them the oxygen they need all in one fell swoop, okay? Questions on that concept?
How's that working?
How's what?
Because you've got the O2 cord hooked up to the
oxygen. The O2 will go into this guy, and then this will plug right into that non-rebreather mask. So you're gonna be running the air through there.
I see.
Yeah,
Do you
yeah.
have all the things to be able to show us?
I will, yeah, I'll show you guys that on Monday. Yep. Okay, now, if we show up and we have a patient who has a meter-dose inhaler, we can assist them with that at the basic scope, okay? Now, more often than not, we'll see this kind of set up with kids, okay? You'll see this sleeve. So it fits over the inhaler. Basically, you're going to shake up the inhaler, put that on, spritz it in there. The patient is then going to breathe in from the tube. I had a buddy growing up whose little brother was a really severe asthmatic, and I've seen these work quite a bit. They'd spray it into the tube, and he would just inhale into the tube, and he'd be okay. Yeah.
Don't they just use those yellow things that go over the actual mouth and nose?
I don't know what you're referring to.
So for albuterol,
Mhm.
Denise has one, and it's like a whole mouthpiece, and it goes over her face,
Mhm.
and then she just takes a breath in.
It's the same idea. It's just a different type of spacer. Yeah, I see what you're saying. Yeah, the ones that are shaped more like a non-rebreather mask. Yeah, it's the same thing. You're just going to spray it in there, and then they breathe. It's just different manufacturers. This is the one I've seen more commonly, though. And then you also have small volume nebulizers, right? So that's going to be when we nebulize, that's what we're using. So the nice thing, they're easier to use than meter dose inhalers. We don't have to time it with the patient's breath, right? You're going to shake it, have them exhale, form the seal with their mouth. As they breathe in, we give it a puff. All we got to do is get that air flowing, and they just got to try and take deep breaths, okay? Downside, takes a little longer to deliver the medication, but if we're going to be giving this med en route to the hospital, where are we going fast, right? They have time, they can work their way through it. It is going to require external oxygen, which we will carry, okay? Now this is most effective in patients with moderate to severe respiratory distress. We typically will use it for any asthmatic who's wheezing, okay? And then we can also, nice thing is that you can hook this up to CPAP, which we'll talk about CPAP next couple weeks, but it's called continuous positive airway pressure, CPAP, okay? We'll talk all about it. Essentially what it is, does anyone ever put their, this is probably not the right way to say this, but does anyone ever put their head out the window while they're on the freeway, right? What CPAP is, essentially you're doing that and then you take a big breath. It's just a constant stream of high flow oxygen, so when you breathe, it forces you to inhale. Works really, really well. We'll talk about uses for it later, okay? Questions on nebulizers. So our dose of albuterol, 2.5 milligrams nebulized. Okay, now when it comes to patient medications, right? So patient assessment includes finding out which meds they're taking, gives us vital clues to their condition, guides our treatment, and then it'll be useful to the emergency department. Okay, this is going to be part of that sample history. Okay, remember medications, what meds are they taking? It can help guide our decision. Okay, so do not underestimate the importance of obtaining a medical history, medications included, okay? Now, medications are often not taken as prescribed. There's several reasons for that. One, if it's something that's like an opiate, they tend to be abused, or benzos tend to be abused. Things like, what's the big one kids talk about? Xanax, that's the one, right? That's oftentimes an abused prescribed medication. But there are also times like people can't afford it, right? Or they're making it last because they can't afford it, or they're running out and they're gonna be out of town. They don't know when to get new pills, okay? All sorts of different reasons. And then also understand if a patient's taking their own medications, that can alter what we're seeing, okay? That can alter their clinical presentation. Okay, now last couple of slides, hang in with me. So inappropriate uses of medications that could lead to patient harm are gonna be medication errors. How can we avoid medication errors? Our rights, yeah, our 6 rights, exactly. So, may be possible to minimize errors if circumstances are understood, and then make sure the environment does not contribute to errors. This is kind of going back to it, why I emphasized, if there's a 0 point and the zeros before, emphasize the 0. I've seen the mistakes made, okay? Now also when you're gonna be handed a medication, make sure you're double checking things, but I've seen the mistake where people have drawn up 3 milligrams of epinephrine. We had to drain it out and get the correct dose. You can do some serious damage. So 0 point, emphasize the 0 because things are loud. Don't let your environment dictate your medicine that you're trying to provide. Now, if we do make a medication error, it happens. People make mistakes. You're all gonna make a mistake at some point with meds. It happens. We've all had at least one type of medication error. Okay, first things first, make sure we're taking care of our patient, okay? Make sure we're notifying medical control, okay, letting them know, hey, I made a mistake, this is what you're gonna be seeing, we're gonna call the hospital we're showing up to, so they're aware. Follow your protocols, there's probably gonna be paperwork you're gonna have to fill out, okay? Make sure when you're charting it, you're being thorough, accurate, and honest, right? Don't lie, don't try to hide it. If you try to hide it and you get caught, that's when you start losing your job, okay? If you're forthcoming with your mistakes, you're a lot more defensible. And then talk with your partner, supervisor, or medical director. They can kind of help guide you through the situation. Medication mistake I made one time. So I had a patient one time who had, I thought it was vertigo. He was basically had the spins, throwing up, nauseous, vomiting, the whole nine. Tried giving him Benadryl, which was our protocoled medication. Did not work very well. So my preceptor said, hey, why don't you try calling into medical control and ask if we can give a benzo. Benzos historically have helped. That was in the protocols prior to me working where I worked. So I was like, sure, I'd never heard of it, but he's my preceptor. So I gave him a go. Called the medical control, and medical control said, hey, make sure you're, like, that's fine, just make sure you don't give him too much. This could be a cerebellar stroke, not vertigo. I said, cool. So I gave the patient 1 milligram. Our dose was 1 to 2.5 milligrams for this benzo. I gave him 1. Nothing happened, to which case my preceptor said, hey, why don't we try giving him a full 2.5? I said, okay. I gave him 2.5. I ended up bringing this patient in on a non-rebreather mask because I knocked down his respiratory rate so bad. And then I got yelled at by a doctor, which I can tell you does not feel very good. And turns out that patient was indeed having a cerebellar stroke. So a lot of things went really sideways on me really fast, okay? Once again, I owned up to the mistake. I called my supervisor on that day. I also charted everything, okay? You're gonna make mistakes. Own them, it happens, okay? Questions on this at all? Okay, let's